Evaluation of chest radiographs in children of different age groups in normal and pathological states clinical cases. The objective of our class today will be to provide a general approach to pediatric chest X-rays interpretation depending on age in normal state and most prevalent respiratory diseases, and to describe unique imaging findings that indicate certain pathologies in community-acquired pneumonia, bronchiolitis and asthma, and foreign body aspiration. Interpreting chest X-rays provide a great deal of information and less expensive than other imaging and use very little radiation. Often provides the information that tells us we need to do additional imaging, but it can be hard to interpret in children. Chest X-rays look different in children and change with age. Also, we may deal with problems with limited cooperation and timers, which may confuse our interpretation. Interpreting chest X-rays, there are several methods for interpreting chest X-rays, and it is important to find one that suits you. An overview of one of these methods is shown below. We have A, B, C, D, E, E, F, G, H, I method, and A is for assessment, B for bones and soft tissues, C for cardiac silhouette, D for diaphragm, E for effusions, F for fields, G for great vessels, H for killers, and general impression. Of course, we will not speak all of these peculiarities about. We will speak about some of them. First of all, how to start assessment. You have to check the patient's details, check the type of X-ray film, and it is erect or supine position taken. Check for features to ensure that the film is of sufficient quality. It is very important, such as rotation, inspiration, picture, and exposure penetration. In this class, we shall speak about X-ray posterior anterior films and lateral views. What we start with? We may start with airways and to check is trachea located midline or deviated. Mostly it is located slightly to the right side. Is anything collapsed or plugged? What is angle of carina, which is normal 90 degrees? Check for bones. Trace outlines for clavicles and full ribs for fractures. Follow the curves of ribs. Posterior ribs are more horizontal and anterior are curved. And you have to observe at least 9-10 posterior ribs for good quality picture. And check cardiac silhouette and position of the heart. For example, in these pictures, we may observe normal heart size because cardiothoracic index is less than half of rib cage width, no any dextrocardia, and in this picture, we may observe cardiomegaly because cardiothoracic index exceeds 50%. What about abnormal heart silhouette or shapes? For example, widely known such abnormal heart shapes in such heart defects as boot-shaped heart, snowman sign, and agonist ring sign, which associates with such congenital heart defects as tetralogy of Fallot, total anomalous pulmonary venous return, and transposition of great arteries. But most important we shall speak today about is lung fields. What changes you may observe in them? Are they unilateral or bilateral? Are they multiple? And it is right side or left side? Is it what is the projection of chest X-ray film you may observe? We shall not speak today about great vessels, but it is important when you are dealing with cardiomegaly to suspect what is it. So, chest X-ray changes with age. Children are not small adults. That's why if you see here normal chest X-ray of 3-year-old child, it will be at all different as compared to this one, normal chest X-ray of 12-year-old child. And with aging, we observe huge changes both in middle shadow, mediastinum, and as well as lung fields. Cooperation may be limited as well. Okay, you may see the chest X-ray in posterior anterior view, which may tell us that we may suspect some pathology because of decreased aeration. But in the same chart, taken X-ray 2 minutes later tells us that it is at all normal. Why it has happened? Because of phase of breathing taken. Expiratory may cause issues. This is the chest X-ray of 14-month-old toddler with cough and wheezing. And we may suspect the child has cardiomegaly or decreased aeration, but when you will calculate posterior ribs, you will observe that it is only 7 ribs visible, which tells us that it was done on expiratory phase. But to receive good quality chest X-ray picture, you have to do it on inspiratory or mid-inspiratory phase, which associates with better quality. The same child on the left view, you may observe that it was done on expiratory phase, and truly speaking gives us a lot of problems to interpret it. And 2 minutes later, taken chest X-ray of the same child gives us the possibility to analyze it. No pathology we may observe, and in this case we may observe not 7 but 9 posterior ribs. So another problem which may cause misinterpretation of chest X-rays in children, it is thymus. Thymus may cause confusion. So it is a huge organ which is located in anterior mediastinum, and it may cause problems because thymus increases in size from birth to puberty, but the child grows more, so the thymus appears smaller in elder children. Thymus is highly variable in size and appearance, and thymus can shrink within hours due to illness, may change suddenly in size, especially after chemotherapy or any another treatment. So this is the chest X-ray of 2-month-old child, and you may observe such shadow which we may suspect pathological, but it is normal due to age. It is thymus. All this consolidation looks like. So, and thymus size depends on age. This is the chest X-ray of 2-month-old child, 7-month-old child, and 12-years-old child. And we may observe that in elder age, we can't observe this thymus shadow. But if you observe it in this age, and this is adolescent age or school age, you may understand it is never normal or physiological, so it might tell you about pathology. So, on the right picture, you may observe adolescent chest X-ray and no any signs of thymus enlarged, and in infant we may observe very big size, which tells us that mediastinum shadow is enlarged. Another signs typical for benign thymus enlargement is sail sign, shown here with arrow. Thymus can be very large, and it may cause wave or sail sign, typical changes. But if no sign of thymus in the context of severe immunodeficiency is visible in these small age children, so infants up to toddlers, you may consider DiGeorgi syndrome or congenital immunodeficiency. This picture shows us the sail typical benign enlargement, sail sign of thymus enlargement visible in closer view. This is also another shape of thymus typical for small children, shown in this chest X-ray picture for 4-month-old child. And for 7-month-old child also enlarged thymus with wave or sail sign. But in adolescency, we remember that we never may observe it, and it tells us about pathology like tumor. Child comes to you with cough, child is 2 months old, and you take chest X-ray. You observe mediastinal shadow enlarged, but you see that no any structures are deviated, no any structures are shifted, and behind this shadow in the middle you may observe normal lung markings. So why it is? It is because of physiological enlargement of thymus in this age group. So, and another sign which may observe on a closer view, it is scalloped sign, which caused by crossing of anterior parts of ribs of fatty tissue of thymus, and it also tells us that it is truly thymus, not any another masses. It is shown with arrows here. So interpreting chest X-ray tells us that first of all you have to pay attention to mediastinal shadow, and in newborns heart size can be a little more than the half of width of the chest. The lateral film is often more accurate than the frontal film in interpreting heart size, and a good breath is required to judge heart size. So on this chest X-ray, we may suspect heart enlargement, but due to age, it is normal because it is timeless, and from another point of view, it is done on expiratory phase. You see that expiratory phase gives us a problem for interpreting because of more horizontal position of heart, and in inspiratory phase, this shadow of heart size is less increased and it is normal. And heart size changes much more on the frontal as compared to the lateral view. What terminology we may use while describing or interpreting chest X-ray? So these are as follows: pneumothorax, consolidation, atelectasis, and diffusion. So most of them associate with radiopaque, hypolucent changes, and only pneumothorax associates with black color, radiolucent, hyperlucent change. So what is pneumothorax? It is air between the pleura and chest wall. And you may observe pneumothorax here, shown with the blue arrows. You have to describe, is it both sides? Mostly it is one side located, and in childhood it is associated with connective tissue conditions, also can appear spontaneously, and how to describe it. So for example, on this chest X-ray we may see lateral and anterior zones located on right side pneumothorax with a lung atelectasis, and child is rather young. This is newborn's chest X-ray picture. Truly speaking, in children the pneumothorax location differs a lot as compared to adulthood. So where you may see in these both chest X-ray pictures pneumothorax. Pneumothorax is located more anteriorly and in middle zones as compared to adulthood, and in elder children as well it may be located more laterally. Another changes are atelectasis. It is a loss of lung volume secondary to collapse, and you may observe it, this lung atelectasis, with a picture of linear increased density on chest X-ray. The most common cause of atelectasis is bronchial obstruction with loss of air-filled areas and reduced aeration. Sometimes we may observe obstructing lesions. In these two chest X-ray, we may observe densities in upper lung fields on the right side. And what is what? How to analyze it? First of all, you have to pay attention to intensity of this density, and more dense, less dense, and the location of trachea. For example, on the left-sided picture, we may observe density with trachea shifted to it, and on this one, the density is more intensive, and we may observe trachea shifted outwards. So, what is what? And we may tell that atelectasis is located on the first picture because of loss of aeration, causes shifting of trachea to this side, and this density is caused by neuroblastoma. Another changes is consolidation. So what is consolidation? May be caused by, it may be pneumonia, it may be another changes, maybe pus, infection, blood, diffusion, and so on. And is it located on right or left side? Is it dense or not? What it looks like? You have to describe. For example, in this chart we may observe right-sided consolidation located in the lower and middle lung fields. Very important in pediatrics to take into account overall assessment of patient, but also not to mix with another shadows. Consolidation, you have to rule out the scapular shadows on both sides, visible here, for example. So now we will observe video of 7-month-old child with 3 days history of cough, grunting, and high-grade fever.
There we go.
Also, we have seen retractions. We have seen this child manifesting with tachypnea. So we may suspect in such combination of clinical symptoms, we may suspect the child has pneumonia. So pneumonia is the most frequent cause of consolidation of lung field, and it might be viral or bacterial pneumonia. It might be lobular or bronchopneumonia or lobar pneumonia. And in this chest X-ray, we may observe typical right middle lobe pneumonia. But of course, pneumonias may differ in their presentation in chest X-rays. For example, what do you consider? Where do we see pneumonias? Of course, most typical it is manifestation in the middle picture. It is bacterial because it involves segments and lobe totally, and this is chest X-ray normal. If you have interstitial changes, hazy, diffuse, opacity, small size, it might be viral pneumonia. Very typical for children. In elder children, we may observe in this chest X-ray picture typical manifestation of right middle lobe pneumonia, and the same in younger child, also right middle lobe pneumonia. Child with fever and cough comes to you with such complaints, and you decided to take chest X-ray because of suspecting of pneumonia, and you may observe consolidation located in almost involving totally right lung, and this is consolidation which may tell you that you suspect pneumonia, but also you may observe laterally more dense opacity, which tells you about possibility of complication like pleural effusion, and it is approved by visualization only one hemodiaphragm on the lateral view. This child also have the same changes, right-sided lobar pneumonia with peripneumonic effusion. Another typical changes for childhood in case of pneumonia is visible on this chest X-ray. Typical pneumonia, we will discuss what is it. The child is 7 years old, has cough and fever, where you may observe consolidation. So if you will be attentive, you may see it near the heart shadow, and it is typical round pneumonia. Round pneumonia is typical only for children up to 5-8 years old. It is not masses like in adulthood, which may tell you may suspect something very serious like tumors. One more child who is 2 years old, having cough for several days, and you see the same round shape, which tells you that it is round pneumonia. So it is typical for childhood, which never observed in adulthood. This child manifests with right-sided total pneumonia, but also you may see such complication which associates with typical staphylococcal origin etiologically of pneumonia, like pneumatocellular or parenchymal destruction with air-filled opacities. On these chest X-rays, we may observe children with right upper consolidation on the first picture and on the second picture. Where is pneumonia, where is not? So if you will remember, we have discussed already that in small children, so consolidation, such mimics consolidation shadow, it is maybe thymus. In this case, it is thymus, because behind this opacity, you may observe normal lung markings and no any shifting of normal structures of mediastinum and lung fields, as compared to this picture where we may observe more dense masses and shifting of trachea. So on the right side we may observe pneumonia, right upper lobe pneumonia. So you have to analyze it to assess what is the density, how much it is dense, this opacity, and do we have shifting of trachea and main bronchus. So suspecting pneumonia also have to pay attention to diaphragms. Does it appear symmetric? Normal for right hemodiaphragm to be slightly superior compared to left. And what are the about costophrenic angles? Are they sharp? If they are not sharp, you may suspect presence of pleural effusion. Pleural effusion it is transudate or exudate present in pleural space, and in this case we may observe right-sided pleural effusion in the chest X-ray. In the child whose chest X-ray we may observe on the left side, we may observe consolidation of the right lung with suspecting right-sided pleural effusion, because costophrenic angle is not visible and it is approved by CT scan visible on the left side. Pneumonia and parapneumonic pleural effusion. Also, you have to remember that not in all cases immediately after clinical symptoms manifest we may observe typical changes of what is causing these manifestations. For example, in the first days of sickness, we may observe some consolidations present on the left side of lung fields. Child has cough, fever, child is 8 years old, but taken several days later, picture approves that this child has left-sided pleural effusion, maybe also parapneumonic origin. Also this chest X-ray of picture of 12-year-old girl representing with dyspnea, coughing, fevers for several weeks represents that we may see not only cardiomegaly, nevertheless this side not visible, but we may suspect that cardiomegaly is moderate. Not visible costophrenic angle on the left side tells us that we also have pleural effusion, and in this case child having autoimmune connective tissue disorder may manifest with such syndrome as serositis, pleural and pericardial coinciding effusion. Now, dear colleagues, we will observe video of 5-month-old child with 3 days history of cough, wheezing and low-grade fever. We have seen the child demonstrates respiratory distress caused by wheezing, tachypnea, retractions, nasal flaring, and all these symptoms may be caused by bronchial obstruction, most often due to this age bronchiolitis or another obstructive bronchitis or bronchial asthma. So the bronchiolitis chest X-ray findings are mostly at all non-specific. And what we may observe in this chest X-ray of child. First of all, it is ill-defined small or hazy clustered nodules on both sides and areas of air trapping characterized by hyperlucency, hyperinflation of lungs. But as well as in asthma, in bronchiolitis, chest X-rays are not recommended, but unfortunately still routinely obtained. And in this chest X-ray with patient with asthma, we may observe that lungs are hyperinflated on both sides and more than 9 or 10 ribs are visible. Also, another non-specific finding is flattening of diaphragm. If a chest X-ray picture is not recommended routinely, only in cases of some complications you may order chest X-ray of child with asthma. This is the chest X-ray of 1-year-old patient with asthma. He is intubated, means he has complications, might have. And here it is visible endotracheal tube. On this chest X-ray we may tell that lungs are hyperinflated, especially on the left side, and more than 9 ribs are visible, posterior part of ribs. And another non-specific finding is flattening of diaphragm on both sides. Another chest X-ray of a child who has more severe exacerbation of asthma, and look by yourself what findings you may observe here. Now I will answer what changes we may see here. First of all, it is hyperinflated lungs and costophrenic angles are rather deep on both sides and diaphragm is flattened. And also we may observe pneumothorax. as well as atelectasis on both sides. And these are non-specific findings. Atelectasis may be caused by bronchial obstruction with mucus in case of asthma. Another findings which is very important and also may be manifested with similar symptoms in clinical picture, like wheezing, dyspnea, coughing, low-grade fever, no fever, is foreign body aspiration, which you have to suspect in any child up to 3-4 years old. But foreign bodies are mostly not visualized on chest X-rays. Exception is metal origin foreign bodies. To suspect foreign body aspiration, you have to look for signs of air trapping and to compare lung fields on the right and on the left side, are they the same or not. Look at this chest X-ray and what you may suspect, why foreign body may be present here and where it is located. If we will go through our strategy of examining or of assessing the chest X-ray step by step, on the stage F, where you compare in lung fields, you see that left lung appears hyperlucent and more inflated as compared to right lung, which may be the clue to suspect foreign body aspiration in this case. And later on, almond nut was removed from left bronchus in this child. So in this case it was left-sided foreign body. Another chest X-ray of the 2-year-old child with abrupt onset of stridor, noisy breathing. What you may see here, also if you will compare right and left lung fields, right and left, you will see that they are not the same. We do see asymmetry. And later on, foreign body was taken off from the left bronchus due to bronchoscopy. Chest radiographs are most commonly normal with foreign body aspiration. Most commonly they don't represent any changes. If the foreign body has reached the lower airways, findings such as unilateral lung hyperinflation, which we have seen already earlier, atelectasis or mediastinal shift and consolidation can be seen. The most common chest X-ray presentation of foreign bodies in children is hyperinflation, primarily because of increased compliance of the pediatric airway and leading to ball wave mechanism, which cause air trapping and hyperinflation of the side of foreign body aspiration. This is the image of 3-year-old boy with a history of coughing and choking while eating mixed nuts. Frontal chest X-ray shows asymmetric hyperlucency and inflation of the left lung as compared to the right. And later on, nuts were removed from the left mainstem bronchus at bronchoscopy. Now we are coming to post-test stage. So, test number 1. This is a chest X-ray of 3 months old child who represents with 3 days of cough, rhinorrhea and fever. Family history is positive for asthma with his mother. The patient has been seen to cough during breastfeeding, but he completed his feeds after nasal suction today. He has had 2 similar episodes. His chest X-ray is shown. What is the diagnosis at this time? D. Georgi syndrome, lobar pneumonia, thymomegaly, or viral upper respiratory infection. Due to chest X-ray, what is visible here, the correct answer is thymomegaly. Due to age of child 3 months old and not visible serious changes, no any consolidation, normal costophrenic angles, normal heart shadow, only medial shadow is wider but in upper mediastinum, and due to age we may see only thymomegaly because all other structures are normal, located, trachea, and behind the masses in mediastinal zone we may observe normal lung markings on both sides. This is the answer. Test number 2, and this is the same child. In the age 5 months old, you see that thymus was decreased in size because of involution. Physiological changes in size happen with age. This is the second test. This is a 3-year-old with chief complaints, coughing and difficulty breathing. There is mild bilateral stridor on exam. Her cough sounds slightly bronchospastic but not barking in nature. More clinical history indicated that the child was jumping on a bed while eating some food and when she began choking. Since that time, she has experienced respiratory difficulty. What do you suspect? Observe the frontal and lateral view of chest X-ray. It is foreign body, viral pneumonia, bronchitis, or croup. And the correct answer is foreign body. Bronchoscopy revealed bilateral bronchial peanut fragment foreign bodies. Of course, we may suspect it because of asymmetrical changes in lung fields and hyperinflation, maybe due to air trapping, and flattening of diaphragm tells us about this. Next case. This is a 9-year-old male with history of fever, headache, nausea, and coughing. Observe this chest X-ray on frontal and lateral view and suspect foreign body, viral pneumonia, asthma, or round pneumonia. What is the correct answer? The correct answer is round pneumonia. On right side, you may observe the round shape, so consolidation, visible also on lateral view, and it tells us that nevertheless not only up to 5-8 years old but even a little bit elder age children may manifest with typical only for this age group round pneumonia, which never visible in adulthood. Next case. This is a 10-year-old male who came to the emergency department with history of coughing and fever. Poor breath sounds were noted on the left side. What do you suspect? Pneumothorax, pneumonia, asthma, or atelectasis? And the correct answer is atelectasis. On the left side, we see that it is big consolidation and trachea, which is located slightly to the right in normal situation, is shifted slightly to the left side, and also we can't observe air abruptly stopping on this level. And what has happened? On the original film, there is a suggestion of a 1.5 centimeter cylindrical foreign body in the left mainstem bronchus, and further history revealed that the child had swallowed a plastic bullet several days ago. So the correct answer is foreign body. And to summarize, guys, all information we have discussed today. How to interpret chest X-ray in children. First of all, remember about physiological age-dependent findings which may be observed only in this age group. So first of all, it is timers, which may cause a misinterpretation, and you may suspect pathological findings, but it is normal physiological findings. So timers. Also, don't forget about comparison of lung fields on the right and on the left side, so about symmetry, because foreign body aspirations is rather prevalent in children up to 3-5 years old and may be missed because sometimes we don't observe any findings at all. Also, analyze the location of trachea, main bronchus, and if they are shifted to the right, to the left, also which help you to reveal pathological changes. Don't forget about killer zones, about cardiomegaly presence or not, because in children mostly heart shadow a little bit wider as compared to elder people, and cardiomediastinal contours a little bit different. Don't forget about diaphragm and killer zones. Thank you very much for your attention and good luck in your careers.